Hello, everybody. So this is a 64 years old male. So we are live now in our unit, and this patient was sent because of jaundice and suspected history of biliary stone. But we already performed on US, and we didn't see anything in the main biliary duct. There was not stones, and there was during the U.S. we see also big dilation of the biliary tract, so the intrahepatic biliary tract. So we decided to do cholangioscopy because we didn't arrive to see very well. We also detect a cholecystitis with stones, and we see ascites, a small amount of ascites in some areas suspected of carcinomatosis. So we are doing now a spyglass now. You see here. So we see this area. This is stenotic area, and you can see very important pattern that are very interesting to be discussed today. So we have here uh, some areas of neovascularization here. You see here on your left, okay, and this is an infiltrative tumor. This is not a mass, and in according to the last publication made by our team, this is without cholangiocarcinoma, advanced cholangiocarcinoma, without any chance of surgical resection. So you can see here the extension, you can see here the neovascularization, and there is a lot of fibrosis here in this area. So there was a small discussion here before about the possibility of this patient had to have sclerosing cholangitis. So the situation is that even if this patient have sclerosing cholangitis here, there are neovascularization here, and probably there is a neoplasia, there is a cholangiocarcinoma inside. So to my opinion, this is a cholangiocarcinoma. This is a 64 years old male with weight loss, important weight loss, and all the aspect found at during US confirm also help us to arrive to this diagnosis. In addition, you need to know that in our series of more than 100 patients for the new classification for cholangioscopy, the presence of this infiltrative lesion with neovascularization give us a diagnosis of cholangiocarcinoma of with an accuracy in around 93%. But now I need to solve this patient because this patient is in cholangitis and also have a cholecystitis. So the approach that I will do now, because I am I have a diagnosis now, I have a very good suspect diagnosis. I will use one of the tools that I use in my day-to-day, that is to use confocal laser under microscopy to have immediately diagnosed, and also I will take biopsies, and also I will put some stents here, and I will drain this gallbladder because there is a cholecystitis and probably no surgical option, and we can do that also in the same step that we will show you. Podemos pasar la fluoresceína. Okay, I will show you also. I don't know if we can see my image, my endoscopy image. I will show you an adjustable endoscopy valve. This is from US Endoscopy. It's a very good tool. I really like it. I don't know if you are looking. ¿Podemos mostrar mi cámara? ¿Me puedes confirmar si estamos mostrando mi cámara? So This is a very nice adapter. The name is Urosil, and I prefer to use this. You see my scope here? I don't know if podemos mostrar mi endoscopio, por favor. So here, you see this adapter is a different adapter, and I like to use for cholangioscopy because it's very easier. You see here, I can perform my aspiration by this area, by this channel, and also I can pass my probes or my biopsy forceps for this side, and I don't need to, it's easier to seal and to avoid, the exit of Billy's or everything. It's very nice adapter. I really like it. So I will use this endoscopy adjustable adapter. You can see here now. Por favor, podemos mostrar la colangioscopía. There is a neovascularization here with a lot of fibrosis, and there is also the honeycomb pattern here. You see here. So, to my opinion, without doubts, this is a cholangiocarcinoma, advanced cholangiocarcinoma. It's a very nice image. So I will use confocal. This tumor. So now I have my probe here. ¿Podemos mostrar el confocal, por favor? So now, you can see here, very nice image. ¿Puedes mostrar el confocal, por favor? Also big vessels, you see here, 2 criteria, okay? And there is epithelium. ¿Puedes regresar? Regresa un poquito más. Más. Here, no, derecha. No, izquierda. There are some dark clumps with epithelium pattern here. So, to my opinion, there are 3 criteria. For the diagnosis of cholangiocarcinoma to confocal, and confocal give us at least 88% of diagnosis of accuracy, more my 90% that I am having with my visual impression using my spyglass. So I think this is without doubts cholangiocarcinoma. So now we have the optical diagnosis. Okay, we have now optical diagnosis. It's nice, very nice image. So now I will show you. ¿Podemos mostrar mi endoscopio, por favor? So once I finish, I just need to push here. You see, poke, and I can retire my probe very easier, and I am not having a lot of water or bilies coming out. So this is very nice, very nice dispositive. I really like it. Thank you to my friends from US Endoscopy, Marcio Flores. Nice adapter. I really like it. Okay, now I will use my spy bite. I will take biopsies for this area. This is infiltrative tumor, and there is a honeycomb areas also. So, to my opinion, it's a cholangiocarcinoma. So this is how you can use technology just to see and to confirm your diagnosis, and you can take in the same anesthesia, you can solve the problem, complete problem of this patient. This patient is not candidate for surgical resection. No more candidate. So I am here with my fellow Jorge Guzman. Jorge is happy, not for the patient, but just because we are working now. Okay, now I have my spy bite out. Again, I close here and I can fix here, okay, my endoscopy adjustable valve. Okay, abre, open, and I will take 4 biopsies at least, okay? It is very important. The number, I don't know, there are not studies showing that, Sierra, but it will help a lot. More tissue, more information, always. There were some questions the other days from a member of Endo Club talking about how I recognize neovascularization. So neovascularization have a particular distribution. Is irregular vascularization, as you can see here, or in a spider, like a spider. It's easier. I invite you to see our oral presentation in this DDW in San Diego, because we were talking about how to recognize cholangiocarcinoma using neovascularization. And if you see the editorial of our paper, is a very good editorial made by my mentor, Dr. Bertrand Napoleon. And the key is that, but the situation is that when we perform a classification, we need to describe all the criteria that we see, all the microscopic criteria, and then we can fix it now. So now we can fix on the vascularity, that I believe is the key. Abre? Not always, but it's the key, at least in 90% of cases. Cierra. Okay. No water, huh? Incredible, huh? This adapter is fantastic. I really like it. Si tenemos muestra, ¿no? Abre. Cierra. The other tip that I can give you when you do a cholangioscopy is to try to take the biopsies just from the vascularity areas, okay? Because when we take biopsies from these wide areas without vascularity, we will have fibrosis and bad diagnosis from the pathologist, but not because the pathology is bad. The situation is the side. The side, I think, could have a role. There is no data about that, but we can do a retrospective study just to see exactly where was the point? Where was the point of or where were the biopsy taken? Abre, cierra. I will take one more, and then I will pass my guide wire. I will pass contrast just to see the biliary tract, and I will pass my guide wire to do to put metallic stent. One more biopsy. Abre, cierra. Okay, perfect. So now I finish. I will pass contrast now. I will block here, so I will avoid the exit of contrast. I will perform a suction here. No, necesito aspirar. This is a very good tip from my good friend and colleague, Dr. Reichman, just to perform aspiration after you perform the biopsies and send this to pathologists. Okay, this is very good, very, very good tip. Always very smart, yeah. Wait, 1 second. Retira un poco. Retíralo. Okay. You can perform a suction. All that will give you more information is good. Yes. Okay, you can see here. And this you will send for cellularity evaluation. Give me, dame el este. Necesito contraste. Sí. Okay. Tira esto. Very difficult case. Yeah. What? Okay. So now, necesito solución salina. Necesito estén de 8 milímetros largos. O al menos uno de 10 por 10 no cubierto. Y uno. Sí. y voy a necesitar uno de 8 milímetros de diámetro de grosor. Okay, now what should be my strategy? So I can put one stand. I think with one stand will be okay, but I will try to put two. Dame una guía, por favor. I will try to put two. Uncover stand. Always uncover. I can put one because I see that the drainage is complete, but I think in the near future the left area will be also complete taken by the tumor also. It's not a big dilation, but it's probably okay. It will be not so easy, huh? I will let just one, and I will see how it will be. Uh, how it will be. Solo uno de 10 por 10. Huh? I will let just one, and we will see, and we will perform the drainage. I think the bigger. Wait. Momento. Okay. Que retira la guía un poquito. Retira. Empuja la guía. Empuja. ¿Sí? Va, momento. Oh, here. Why not? No. No. It's I don't know if I will arrive to put two stands. I am trying to go to the left. Necesito un balón de dilatación también. 10 por 4. Cualquiera. Debía biliar. Un momento. Empuja. Con ganas. Dale, empuja con ganas. Ok, vamos a retirar un poquito. Momento, voy a retirar un poco. Momento. Retiro un poquito. Ok, empuja. Sigue. Sigue, empuja más. Very difficult. Ok, empuja. 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 The other option is to put a pigtail. There. I will try to perform a dilation. Okay, now I am going out. One of the advantage also is of a spyglass is to, to perform less radiation and to give a direction of our guide wire inside. So there's not a lot of space here in this video track for two stands, but I will try to put a small stand in the left area, in the left uh, video track. I will try, and then to pass a big one in the right space. Even though I think there will be a drainage, the problem is that in the near future will be closed faster. The other option is just to drain one area and the other one by percutaneous radiologist. But let we'll see how we can solve this. So remember, this is a live case. Tama. Okay. So I will try to pass a balloon for dilation. No, dame otro. No, ese no. Balón de dilatación. 4x4, 4x6. No, ese no, dije. Ese no. So I will use an hurricane balloon. Veo un este en 10x10 no cubierto. Okay, comienza a dilatar. So now I am in a very good position. Dilata. Dilata. Hasta 12 atm. So now we dilate just to 12 atm. This is hurricane of 4 millimeters by 4 centimeters. So I will wait at least 1 minute. Quiero otro esfinterótomo con otra guía. Quiero una prótesis de 4 centímetros high. 8 milímetros, ajá. 8.4 si es que hay. Y quiero también una 10x10. O tienes 8 milímetros por 10 centímetros. Metálica. No cubierto. You see the gallbladder? A lot of stones. Sí. ¿Es okay? Desinfla. Ok, empuja la guía. Now I'm perfect. You see? I pass. Perfect. So now I will dilate here also. Okay, dilata por favor. Good maneuver. Good maneuver. Perfect. Okay. We dilate here. So I will have a drain from my left area also. I was thinking about that was impossible, but was possible. Very good. Excellent situation for this patient. Perfect. So now I will last 1 minute more. This week we had a lot of really nice cases, huh? Really nice cases. Okay, desinfla. And I will perform a dilation also of the confluence area. Okay, wait. Here. Okay, comienza a dilatar aquí, por favor. And I will perform a third dilation here. So I will less my guide wire there. My guide wire is perfect, perfect, perfect in place. And I need to pass a second guide wire. Perfecto. Okay. ¿Tenemos de 8% o no? ¿De cuánto tenemos? Ok, 8 por 4 y... Ajá, ok. Perfect. I will wait 1 minute more. And then we need to drain the gallbladder. There is a cholecystitis also. This patient have could be solved by endoscopy directly, avoiding an unnecessary surgery. No, no. I will do the cystic is also take it. Compromise. I will use hot axios to drain, okay? ¿Listo? Desinfla. ¿Ya me tienes listo el esfinterótomo con la guía? Ok, gracias. Perfect. Perfect. Ok, empuja. Empuja. Perfect. Perfecto. Okay. Now I need the sphincterotomy. La guía está pasada. Necesito otra gasa. Ok, empuja la guía. Vale. Ok, ten un ratito. Voy a avanzar. Ok, un momento. So now it's going to the left because it's much. Perfect. You see that maneuver? That is a very nice maneuver. Okay, empuja. No, momento, momento. No empujes tanto. Wait. Empuja. Okay, empuja. I am good. Wait, momento. You see, there is any. There are some communication, huh? Momento. Momento. Oh, perfect. Okay, photo, picture. Okay, empuja. Desarqueado, sí, claro. So me pasas el stand primero, el de 8. So I will put in the left side because ese. I need to go to the angulated area. It's easier to pass first, and then I will pass the other sand in the second. Tienen el linear. Necesito un hot axios 10x10. Perdón, al revés. Ese es el 10x8. Acá. Ese es el 8x4 ahora. Acá. Coge. Cuidado. So always uncover the sand, huh? Not easy, huh? Very good, perfect. Ok, comienza a liberar. Momento. Sigue. Momento. Sigue. Momento. So now I am open. Ok, perfect. Abre. Abre. Ábrelo todo. Perfect. Perfect. Momento. Oh, momento. 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 Let's take. I don't want to lose. Okay, perfecto. So I have my other guide wire there. I'm perfect now. Toma. Vamos. ¿Está listo de alinear? Dile que voy a transmitir el eco. Jala. Ok, un momento. Suelta. Wait. Oh my god. Oh, okay. This will be hard. So now I am trying to do in my long position to give more force to my scope. You see? Oh, 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 oh. Oh, oh. Perdí la guía. I lost my guide wire. I lose it. Okay, ten aquí. It will be a little bit more difficult now. Dame la. So if not, there is not problem. There is a communication, and I am very good. There is the area is drained, but I needed that 8 millimeters sand, but it was I was not I have not more here in my units by 10 millimeters. Okay, empuja la guía. Un momento. No. Okay, empuja la guía. Okay, ten un segundo. Retira. You see, will be a little bit difficult now. Okay, empuja ahí. Now. Yes. Okay, empuja. Okay, un momento. So I pass. You see? Empuja. You see, I pass. Just lateral. So what I will do now is to perform a dilation here also. Quiero el dilatador el mismo hace un ratito. Empuja más la... Empuja más. Ok. Momento. Empuja, 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 empuja. Perfect. I think I am better now. Better than at the beginning. Sigue empujando. Más, más, más. Con ganas. Sigue. 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 Sigue, 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 sigue. Ok, listo. Ok, listo. Okay, now I pass by the side. This you can have, huh? But don't worry. So now I will perform a second dilation here, and I will pass my stand. You see, the left side is already drained. Okay. Balloon. Perfect. 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 Good case. Yeah, on the confluence. Is Jorge asking about the dilation in the confluence or not? Yes, on the confluence, and if I can dilate a little bit more upper, yes, I will do. The same. Right? It's very important. So now more than half, my guide wire, I will push both at the same time. Okay, comienza a dilatar aquí. I will start to dilate here. So now we have 12. Okay. Okay, desinfla. A little bit more. Okay. Okay, dilata ahí. Necesito otra gasa. Dilata, vamos. Okay, perfect. I advance a little bit. We'll wait 1 minute. Very hard. Muy duro. Okay, desinfla. Now I pass a little bit more. Infla. I know that I pass a little bit more because I am, passing my stand. You see? I start down, but now I am increasing. Okay, perfecto. And now I know that I pass a little bit more, so I am going well, very well. And I will try to advance a little bit more and to do a dilation a little bit more inside, and I will be sure to pass my stand now. It's very good. Very good. Okay, desinfla. Vamos a la guía. Momento, no es nada. Okay. Okay. Inflow una vez más. I don't have more space here. I will try to pass again my stand. Probably I can have chance. Perfecto. Okay, dame el stand. Okay, listo. Let's go to see. Vamos, cambia. Empuja. Empuja. Prótesis. Okay, jala. Now I pass better, you see. And what I will try to do now, I am good here. I will try to open, abre, momento, momento, no, no. Cierra. Ok, abre ahí, abre. No, cierra. I'm not perfect. Okay. I need that when I start to open, cierra todo. Perfect. So I am giving more force with my scope. You see, with my maneuver. So now I think maybe we are good. Okay, abre, abre, abre. Uh, no, no, cierra. So I don't have the effect that I want to have. Cierra todo. So probably I need to pass a little bit more. I'm not so far. Okay. I need to pass a little bit more. Okay. So to see here, why not? A little bit more. Just a little bit more. Maybe I can try here. Okay, libera. Dale. 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 No. No, no, regresa. I'm not perfect. Oh, just a small. A little bit more. Uh, Momento. I think it's okay. Podemos cambiar la posición. I think we are just there. En donde sea, solo quiero ver el lado derecho. No, no, no. Quiero suelta la rueda, por favor. Esto quiero moverlo, el arco, girarlo. I think we are good. I think we are good. Yes, we are good. You see? The stand is just after, yeah, the confluence. Perfect. Okay, continúa abriendo. It's okay. Foto. Momento. Momento. Sí, continúa abriendo, por favor. Perfect. Ahí. Perfecto. Sí. Está liberado. Perfect. Okay. Photo. This will open. Perfect. Just in the confluence. Okay, now I finish. The right biliary tract is going well. And now I need to drain the gallbladder. So I will use now US. It's okay. There's air. It's okay. Good. 10 millimeters. That was the problem. The big problem was I didn't have 8 millimeter by 10 centimeters stand, so I want to put just one stand. But the ideally was to use one 8 millimeters by 10 centimeters stand. It's okay, but it's okay. The right biliary tract is also drained, and with the open of the stand, it will improve. So now so here is our gallbladder. So for this case, I prefer to use a needle, trans needle, because there is a lot of risk of to lose my position, and I cannot see very well. So here is the gallbladder, you see? It's not an easy case, huh? You see all the inflammation area here. And this is the stones. I don't have a fantastic position, but it's not bad here. So I will use first a needle and to pass a guide wire to put some contrasts inside. Necesito una aguja 19, por favor. Cualquiera. Normal, sí. So, okay. I will use an spec needle now. Because the situation here is that there is an inflammatory area, but I cannot see very well because there's a lot of stones inside. So I need to drain this. And I need to be sure to be inside. And that's the situation why I am using now guide wire. And I will use my hot axios using a guide wire. I am inside, but I need just to confirm. Okay, perfect. You see, I cannot see. I cannot see my needle inside because there is a lot of stones. That's the big problem. So that's why I am using, you see, I will use a guide wire. Dame contraste primero. So I am here. Más contraste. Okay. Salina. Big, huh? Oh my god. I will try to change my position because I don't feel very well because of the stones and also my position of the needle. So maybe I need to change the position of my needle. I will try to perform my function in another area, maybe here. Ok, déjame aspirar, por favor. Ok, I am in place. Voy a retirar. Voy a empujar la guía. Empuja. Oh, oh. Oh. No, no, no está bien. No, retiro. Ok, un momento. Sí, retira. Ok, empuja. Retira, retira. No, I will try to put to look for another position. Ok, retira. Un momento. I will try to look. I am not in a good position. Again, retira. ¿Salió? Revisa si está bien. Okay. This gallbladder is very difficult. The big problem is big problem is that mm-mm. Always okay. Okay, empújala aquí. Dame para aspirar. Y me das la guía, por favor. Okay, perfect. Guía. Perfect. Now it's perfect. Okay. Let's go to see. Quiero ver la ecografía, por favor, empuja. So I need to switch now. We are almost finished. Check. Gracias. Momento. Sigue. It's better to be guide wire here because we don't see nothing. There is a lot of edema of the gallbladder. There is a cholangiocarcinoma. There is ascites. So it's much sure. I am perfect. Very well. Now I am well. Muestra la... You see, I am very well now. With my guide wire in place. Normally you don't need to use the guide wire. And normally you don't need to use see the fluoroscopy, but in this case is very important. Just to be sure. Dame un 10x15 mejor. I will use a 10-15 because there's a lot of stones, small stones that could plug. So I will use a 10-15 hot access. I am sure now. I am very well positioned now. So I show you how we can use our technology just to solve the case, to have a complete diagnosis and also to have a complete treatment. So I invite you to see our presentation during DDW this year about gallbladder drainage as a prophylactic step in patients with biliary and biliopancreatic tumors involved with the cystic duct. Hala. Cuidado. 10. Ecografía. 10. 10. So you can see here my guide wire here is very well, and I always need to have this vision 10, because if I don't have this vision I am not doing well. This is my triac. This is the way I will pass. 10. Momento. 10. see, my triac is here now. I am very well positioned. I will see if there is not vessel, not vessel. So I'm sure now, and I will do my I'm connected now. Perfect. So now, so I am inside. I am inside. So you see, here there is my distal part of my stand. I am confirming I am inside. Okay, very well. You see here, it's much better now. I can see better. And now I am push, and I will deliver my other part inside my endoscopy channel. I do it, and oops, finish. So, ¿podemos mostrar la parte endoscópica, por favor? Acá retiramos todo. A lot of pus. You see? It's yellow. Okay, I will pass un gastroscopio. ¿Podemos volver a la imagen endoscópica, por favor? A la imagen ecográfica, por favor. So you see, at fluoroscopy, perfect, good drainage. By US, here, this is inside the gallbladder, this is inside my lumen tract. Necesito un gastroscopio, solo para girarlo. Mucho pus. Pus is in English? Pus. Yeah. Purulent? Purulent material. So we are almost finished. So this patient will be really in good condition, at least in 48 hours. He's under antibiotic already. So the problem is that surgery says no surgery, no more surgery. Biliary tract is solved, and the gallbladder also. So now this patient have an option. You see here, this is my hot axis here. You see? Oh my God! Oh my God! So this will open more and more. Very well drained. Perfect. And there is a stone there. Oh. I need water. Perfect. Okay. I will close my transmission. Thank you so much. And don't forget to follow our live channel, Endoscopy live channel.